Hello, everybody. Welcome to today's FSHD University webinar. Before we begin, I wanted to give a little background for audience members who may not have attended our webinars previously. The FSHD Society is the world's largest research-focused patient advocacy organization focused solely on FSH muscular dystrophy. Our mission is to get therapies to our families as soon as possible. We fund research grants and so much more. We are directly involved in research on biomarkers and health economics. We're working to increase access to genetic testing. We're educating industry and regulators about patients' needs and goals through forums like the Voice of the Patient. And we're sharing valuable information to you at our monthly FSHD University webinars so that you can be the best advocate for yourselves and your families when it comes to your health and well-being. So I'd like to introduce today's speakers. Dr. Sanne Vincenten, MD, is a neurology resident who has been involved in FSHD research since 2014. As a PhD student, she has been working on a large natural history study of Dutch FSHD patients, of which the first results are expected in 2022. Recently, she wrote an article on FSHD genetics and reproductive counseling together with a group of Dutch neurologists, including Nicol Voermans, and clinical geneticists. Nicol Voermans, MD, PhD, has been working in the field of neuromuscular disorders for over 15 years. Her current research focuses on clinical and genetic features of FSHD, both in childhood and adulthood. Together with the Department of Human Genetics at Radboud University Medical Center, her department constitutes the Dutch FSHD Expertise Center. And I should mention that both Drs. Vincenten and Voermans are at Radboud Medical Center, also in the Netherlands. In today's webinar, our speakers will discuss FSHD inheritance, prenatal diagnostics, pre-implantation diagnostic options, and pregnancy. And we will, our speakers, our primary speakers are from the Netherlands, but where there are situations specific to the United States, I will do my best to respond to those. So,
hello, everyone, and welcome to the FSHD University webinar about FSHD genetics, reproductive counseling, and pregnancy. June introduced us quite well, so I don't think I have to add anything to that. I will be doing the talk, and Dr. Nicol Voermans will fill me in if I will, if I'm not sure what to answer. So Nicol and I are both connected to the Dutch FSHD Expert Center together with a few other neurologists, rehabilitation specialists, and clinical geneticists. And in addition, we are part of the FSHD European Trial Network. And we recently co-wrote an article about FSHD genetics, the diagnostic process, reproductive counseling, and pregnancy together with our colleagues from this expert center. And therefore, we were invited to guide you through these complex subjects today. We're not sure if she will be making it, but probably Dr. Jacinda Sampson will, who is working at the Stanford University Medical Center, will provide the US perspective for our talk. Otherwise, June will fill you in on the possibilities and regulations regarding the subjects we are covering, because there are varying regulations for different countries and even different US states. June, you can interrupt me if necessary if something is definitely wrong, and otherwise we will discuss differences in regulations later. So the reason we wrote the article was that Dr. Voermans and her neurology colleagues received a lot of questions regarding the subjects of pregnancy genetics and reproductive counseling. And because these subjects are all quite complex and they had not been written down together before, we wanted to fill in that gap. I want to start my talk by telling you that I'm going to try my best to explain everything in the best way that I can, but that it's possible that it's a lot of information and it can be quite much and quite hard to follow. So I will pause my presentation a few times to give you the opportunity to ask questions. But I also want to remind you that FSHD is a complex genetic disease and that it takes most people, including me, some time to completely understand it. So if anything remains unclear after this talk, don't hesitate to talk to your own physician about questions you might still have. I'm going to start with explaining some basic genetic principles, after which I will tell you more about FSHD genetics, and I will cover both type 1 and type 2 FSHD. Then I will talk a bit about variability and clinical severity that exists in FSHD and about FSHD inheritance. And we will end the webinar with reproductive counseling options and some information about pregnancy and delivery in FSHD patients. A summary, and we'll leave some room for discussion or extra questions if necessary. So as you might know, there are two types of FSHD, FSHD type 1 and FSHD type 2. And of all FSHD patients, 95% is FSHD type 1. So it's the most known FSHD type, and less than 5% of FSHD type 2. FSHD type 1 and type 2 look the same on the outside, so all patients have the same symptoms. However, FSHD type 1 and type 2 are genetically different. So I will try to explain the genetic differences between the two types later in this talk. As you see in this image over here, your body, I will start by telling some basic genetics, and then I will proceed with the FSHD genetics. So your body is made of cells, and cells all have something inside that is called a core or a nucleus, which contains all genetic material. And this genetic material is stored in a specific amount of chromosomes. These chromosomes consist of rolled up DNA, which in turn consists of different genes. So genes are specific regions of our DNA that are used to direct processes in our body by manufacturing specific proteins. If you are unfamiliar with the genetic terminology, which I imagine most of you are, the information on the last slide might be difficult to understand or to process this fast. So to simplify things, we sometimes use a metaphor. You can see all DNA we have in our body as a cookbook, as you see here on the left. And this cookbook, this contains recipes, which you can see as the genes. So the genes contain the information that is needed for the body to create a protein, or in terms of the cookbook, a pasta. So I will be switching from the genetic terminology to the metaphoric terminology in this talk. To explain a bit more about FSHD genetics, we go back to the chromosomes I just explained to you about. So every human being has 23 chromosomes, and 2 of these chromosomes are most important for FSHD genetics. And these are chromosome 4, which you see over here, and chromosome 18. And chromosome 4 is both interesting for FSHD type 1 and FSHD type 2 because it consists the D4 Z4 repeat RA. And chromosome 18, on chromosome 18, the SMCHD1 gene is located, and that gene is only of interest for FSHD type 2. So let me start by telling you a bit more about FSHD type 1. In FSHD type 1, the problem is located on chromosome 4, and more specifically on this D4Z4 repeat RA, which is located at a long arm of chromosome 4. The D4Z4 region lies in this part of the chromosome, and this is a region that normally contains 11 to 100 repeats, as you can see over here. So this is the chromosome, and here we see that here is the D4Z4 array, and this repeat D4Z4 has normally repeats itself 11 to 100 times. If it repeats itself 11 to 100 times, that's the normal situation, so a person does not get FSHD. However, in FSHD type 1 patients, this region is shortened. So instead of 11 to 100 repeats, this region is only repeated for 1 to 10 units. So it's a lot shorter than in the normal situation. This is quite unique because this is actually a piece of DNA that's missing. And it took scientists a while to figure this out because it's very rare to be for a disease to be caused by a missing piece of DNA. I will explain later how this results in the symptoms FSHD patients get, but to make things more complicated genetically, one additional piece of DNA is needed for a person to get FSHD, and that is the a specific end of this D4C4 region. So at the end of the D4C4 region, you have something we call a haplotype. It's the ending of the region, and it's either an A or a B. And if it's an A, which we call the permissive heptotype, or the 4qa haplotype, so the long arm of the fourth chromosome, and then the A. If you have the A on the end of your D4C4 region, then you can get symptoms of FSHD1. But if you don't, if you have a B, then usually persons do not get FSHD symptoms. I will explain why this is important more later in this talk. So FSHD type 2 is genetically even more complex than FSHD type 1 because it's a digenic disease, and that means that it's caused by a combination of two different genetic problems, which are also localized on two different genetic locations. So as in FSHD type 1, one part of the problem is contraction of the D4C4 repeat region. In FSHD type 1, this contraction is 1 to 10 units, but in FSHD type 2, it's moderately contracted. So it has 8 to 20 units, so it's a bit longer than FSHD type 1. It also needs this 4qa ending. In addition to this problem on chromosome 4, we also have a problem in something that is called a chromatin modifier gene. And in most FSHD2 patients, this is the SMCHD1 gene. And you need, if you have a mutation in this gene combined with a problem in chromosome 4, then you can get symptoms of FSHD type 2. Not all patients with FSHD type 2 have this SMCHD1 gene mutation, about 80%. There are also some rarer variants that we know of, but most are unknown. So we don't know all causes yet. So next, I want to explain you how the genetic problem I've just explained to you leads to muscle weakness. So in the normal situation, the D4C4 region with its 10 to 100 repeats is nicely rolled up in a DNA strand, something we called a normal methylated DNA structure. This means the DNA structure is closed, the pages of the cookbook are nicely stuck together, and its genes or recipes cannot be read, cannot be copied. This is something we want for the D4C4 array. So no protein will be made from this region of the gene. However, when the D4C4 region is shorter, like an FSHD, the DNA is what we call hypomethylated, and that means it's this is normal methylated DNA, and if it's hypomethylated or unmethylated, it's not rolled up like it should be, and this results in the reading of the recipe of the D4C4 region, and this results in the reading of the recipe of the Dox4 gene, which creates Dox4 proteins through transcription. So I guess some of you might have heard about the Dox4 gene before as the cause of FSHD symptoms. The Dox4 gene is a gene that is needed in embryonic stages, but is not needed anymore later in life. So in an adult person, this gene should not be read or copied. However, in FSHD, because of the hypomethylations or the pages that are not stuck together anymore, this gene recipe is read and its proteins are made. The problem is that these Dox4 proteins are toxic to muscle cells and therefore result in muscle damage. So they result in inflammation and muscle wasting and oxidative stress. And eventually this leads to progressing muscle weakness. So as said before, the permissive or 4qa haplotype, so the A or the B at the ending of the D4C4 region is needed to develop FSHD, and this is because this ending stabilizes Dox4 protein. So without this ending, the proteins can do no harm to muscle cells, but if they're stabilized, they can go through with their muscle damaging systems. So as far as genetics are concerned, in summary, FSHD type 1 is caused by a shortened D4Z4 region on the chromosome 4, combined with a 4qa or permissive haplotype ending. And FSHD type 2 is caused by a relatively shortened D4Z4 region on the chromosome 4 with a 4qa ending, and usually combined with an SMCHD1 mutation on chromosome 18. If you want to reread this information slowly, we will share this PowerPoint and it will be recorded after the webinar with all participants. But this information can also be found on the website of the FSHD Society through this link. I'd be happy to answer any questions on FSHD genetics now before I will proceed to the subject of variable clinical severity in FSHD. I'm not sure if there are any questions yet.
I'm looking right now. There's some questions maybe you'll address later around prenatal testing and
yeah, we will get to that.
And there's also a question regarding actual pregnancy and childbirth experience for women with FSHD. So that maybe we'll address.
We'll also later. Yeah.
Okay. All right. Let's go.
Proceed. Let me see. Okay. So between FSHD patients, a lot of variation in severity of symptoms exists. So affected family members with FSHD usually carry the same D4Z4 repeat number. And even within family, so between family members, this clinical severity can vary extensively. Generally, patients with shorter D4Z4 sizes are more affected and older patients are more affected. But there's also a subgroup of cases, which are often family members of FSHD patients, that do not experience any symptoms yet, while they do have the D4Z4 repeat shortening. So this is something we call asymptomatic or non-penetrant persons. So when physicians do not see any signs of FSHD, these persons are called non-penetrant cases. And if the physician does see signs of FSHD, these patients are called asymptomatic. So they do not have symptoms themselves, but we do see, as physicians, we do see something that can match FSHD in these patients. So this picture shows, in short, what I just explained, the patients with the smallest repeats number, so 1 to 3, they usually have the most severe or the most severely affected. And repeat sizes 3 to 7, there's a high penetrance of the disease, and I will explain it in more detail later. But in short, that means that only a few people with this repeat number are asymptomatic or non-penetrant. So usually they get the disease earlier in life. And in families with repeat sizes above 7, this penetrance is lower. So more people in the family do not experience any symptoms, while they do have the genetic problem that causes FSHD. This figure shows how penetrance in FSHD works and how it's related to age. So here you see the likelihood or the chance that a person with FSHD becomes symptomatic or asymptomatic, but has signs. And here you see the age of the patient. So these are the repeat sizes. And as you can see, at age 40, virtually all patients with a repeat size of 5 will show signs of FSHD or have symptoms. While a person with a repeat size of 9 might be 80, but still do not have any symptoms or sign of FSHD yet. So the lower the repeat size, the higher the chance that symptoms will start early in life. And the higher the repeat size, the lower the chance of getting symptoms early in life. And this also leads to the fact that some people will never, with the FSHD genetic problem, will never experience any symptoms during their lifetime. This is obviously not an absolute risk, and it's only applicable to groups of patients, so cannot be used to calculate the risk for an individual patient, but it's just to show the non-penetrance of the disease, and the fact that you cannot say if the person has genetically FSHD, this person will also get symptoms of FSHD, because it doesn't work that way. I will start with telling a bit about FSHD type 1 inheritance. And FSHD type 1 is something we call an autosomal dominantly inherited disease, which means that when one of the parents has FSHD type 1, the risk of having a child that is genetically affected is 50%. So out of 4 children, as you see over here, 2 will have the genetic predisposition for FSHD type 1. Of course, this is a statistical number, so it will not always be the case that only 2 out of 4 children have FSHD, have the genetical FSHD type 1, but this is the average number. However, because of the difference in penetrance, this does not always mean that the child will get symptoms during their lifetime. So especially in the higher repeat sizes due to the incomplete penetrance. Because FSHD type 2 is a digenic disease, there are 2 genetic variations involved, and that means that it's a bit more complicated, the inheritance in FSHD type 2, and it varies. The chance of passing on the disorder, and it depends on the genetic profile of the partner. So it varies between 25 and 50%. Besides passing on the disorder, so both genetic problems that cause FSHD type 2, you can also just pass on one of the 2 genetic variations to your offspring, which make them asymptomatic but carrier of one of the 2 genetic variations that causes FSHD type 2. So there are several scenarios in FSHD type 2 inheritance. This is the scenario in which the partner has no SMCHD1 mutation and no repeat contraction, as you can see over here, so none of both. In this scenario, 25%. So in this case, this is just to make sure all offspring all chances are depicted. But in this case, of 8 children, 2, so 25%, have genetical FSHD type 2, and 50% have one of the 2 genetic problems that FSHD type 2 causes. So they will remain asymptomatic, but they can give this genetic trait to their offspring. So in a scenario in which the partner has a repeat contraction, so you can see it over here, this mother does not have FSHD because she only has one of the 2 genetic traits, but this does increase the chance that their children will get FSHD type 2 to about 38%, so 3 out of 8. So there's even another scenario possible in which both parents carry one of the 2 genetic variants that cause FSHD type 2, and thus together they can get offspring that has genetically FSHD type 2, while both parents are asymptomatic. But many more scenarios are possible, and therefore individual genetic counseling is needed in all FSHD type 2 patients. June, are there any questions about this part of the presentation? Otherwise,
yes, there are quite a few questions that are coming. Some of them are having to do with some of the genetics information you presented before. So here's a question. Do asymptomatic people have the B haplotype on the end, or as opposed to the A?
No, they also have the A. We don't regularly, they should have the A, but we don't regularly test the haplotype yet. So you don't always know. I'm not sure how this is in the US, but in Holland, we only test this haplotype for research purposes or in research laboratories. So I guess we do not always know about all of all patients, but they should have the A ending.
Right. So, and here's a sort of related question. What are the chances of being an asymptomatic carrier if you don't have symptoms? I guess that means you're asymptomatic. So a few things mixed in here, and your parent has FSHD. I think we need to break that apart. One question is, if your parent has FSHD, what's the chance that you will inherit FSHD? And then the maybe second question in there is you may have inherited it, but you could be asymptomatic. How often does that happen?
So if your parent has FSHD type 1, the chance that you have FSHD type 1 genetically is 50%. And the chance that you are asymptomatic or non-penetrant depends on the repeat size the parent has. So the children will have the same repeat size as the parent, but we are not. We cannot give this exact risk number yet because it's we do not know enough about that. So that's something I'm also investigated in my study. But we cannot say if someone will stay asymptomatic or when they will proceed to get symptoms. So we only know statistically seen the 50% that the inheritance risk is, but we do not know the risk of being asymptomatic or not. Right. Besides that, it's dependent on the repeat size.
Is it also dependent on the methylation of the repeat units?
Yeah. Maybe Nicole can say a bit more.
Well, I think I can comment on the previous answer you gave, and that is the likelihood that you're having symptoms or showing signs of FSHD increases with age, and is higher with shorter repeat sizes. Yeah. And that's what Sanne explained before. So there's 50% chance that you will have the same genetic fault as your parents, but the chance that you're having, the likelihood that you're going to develop symptoms or show signs is variable. And that's what the figure which Sanne is showing now clearly shows. It's really dependent on the repeat size and the age. And these curves here are not percentages of patients presenting it, it's likelihood. Yeah. So if you are 50 years old and you have a repeat size of 80% of 8, the likelihood of having symptoms or showing signs is approximately 50%.
Mm-hmm. Okay, thank you. There's a question about the inheritance of the 4QA haplotype. So I think maybe this might be a question having to do with something I just heard of someone talk about it yesterday, that this happened in their family, that you can get a recombination during the passage from one generation to the next, and the 4QA that was in the parental line was replaced by a 4QB. Yeah. But that must be a rare occurrence, but yeah, it does happen.
Rare, but it can happen, yeah, definitely. I did not include the recombination in this presentation because it makes it even more complex, but yeah, that can happen, yeah.
Yeah. And then we have someone asking, can you have the shortened D4Z4 repeat units and the poly A haplotype, but not have the hypomethylation?
I don't think so, but no, Nicole is also shaking no, no.
We usually do not test it in a diagnostic setting. The testing of methylation is a complex technique, which in our country is only performed in research when we are convinced that someone has FSHD, and diagnostic tests do not show FSHD type 1 or type 2, and then we're going to see whether methylation is reduced. But the fact that the reduced methylation is caused by the shortening of the repeat, so it's a logic consequence of the fact that the D4Z4 repeat is shortened. And as a mechanical effect of that, methylation reduces and the reading frame becomes open.
So if I recall in paper from Peter Jones's lab about 6 or 7 years ago, looking at methylation levels in the same families that had different age of onset or severity, did show that you can have different levels of methylation even with the same number of D4Z4 repeats, and that seemed to be correlated with symptom onset. I don't know if that study has been replicated, but that was.
Well, the idea is, of course, that methylation is an epigenetic process. So there are definitely other factors influence it, but I've not come across any cases or read about a shortened repeat with an A allele and then normal methylation. There's a variance in the degree of reduction of methylation, but it's not normal.
Right. That's certainly the case. It's not normal. It might be reduced, but maybe it's 70% versus 30% in someone, a family member who's more severely affected. Seemed that's I'll have to go back and look at the paper, but that was something. Anyway, there was still a lot to be learned about FSHD.
Yeah, definitely.
Really, about the genetics. This is a question, maybe it relates more to therapeutic possibilities. Someone wanted to know if there's any technology that would allow the missing repeat numbers to be added. So for example, inserting additional D4Z4s into that section, or to change the haplotype in a patient from A to B. Can you comment on that?
Well, most therapeutic options they are testing right now mainly focus on the Dox4 protein, but there are some labs working on
CRISPR-Cas?
Yeah, exactly. So indeed to change the DNA, but as far as I know, that has not been tested in humans yet, and there is a lot to be done in that field yet for FSHD. But yeah, that could be a possibility, but it's complicated.
Okay. There's a question. What is the average repeat size in FSHD patients? Is it spread evenly between 1 to 10, like, or equal numbers, or is it kind of a
I'm not sure. In my cohort, which contains 200 FSHD patients, it's 6, but I'm not sure what the average repeat size is in the general FSHD population. I don't know if you have an answer to that, Nicole.
No, but it's definitely influenced by the cohort you are investigating. So if you have a cohort including many children with an early onset FSHD, there will be more shorter repeats. And if you include also family members or families in which only part of the gene carriers have symptoms, it will be longer. 5, 6, and 7 are definitely repeat lengths causing the classical FSHD phenotype, and therefore the most frequent ones. But I'm not aware of I don't know how it will be in the United States, but most likely to be similar, I think.
Okay, here's a question regarding from a patient who says she had onset at age 40 with symptoms, and her parents, who are now in their 90s, never showed symptoms. Does this mean, she's wondering if one of her parents does have FSHD without symptoms?
So they've never been tested. She doesn't know.
I guess not. No.
Yeah, they could be. Does she know her repeat size?
I don't know. Maybe she could type that.
They could be non-penetrant or asymptomatic cases, or she could be a de novo mutation. That's also a possibility. So that she's the first in her family to have FSHD.
Yeah. But de novo mutations are often short repeat sizes and a more severe phenotype. So in this case, I think it's most likely that one of her parents is a carrier and possibly non-penetrant or asymptomatic. And maybe the next time she's going to visit the neurologist, she could, if her parents are still mobile, take them to the neurologist and see whether there are any signs if they want to know.
Okay. Great.
But if you're 90, many 90-year-old people cannot raise their arms fully up anymore.
No, and sometimes it's quite subtle, the things
Yes.
we see, the neurologists see in patients. So they can be asymptomatic, but we see some subtle facial asymmetry or facial weakness or something in the shoulder girdle. So I guess their neurologist can comment on that.
Okay. There's a question, it says, what is the difference between type 1 and type 2? You described the genetic difference. So I think maybe they're asking if there's a phenotypic, or difference in the symptoms or anything else.
No, there is not. It's just a genetic difference.
Okay. Oh, and the person who asked the question before, who's 40, she doesn't know her repeat size and parents have not been tested. So thanks for telling us that. And
just
yes.
to add, my experience is that it often occurs that someone comes to my clinic presenting with FSHD in adulthood and then telling me there's no one in my family with the same disorder. But then if someone comes back with one of their parents, or they think about it and talk about it when they get home to many family members, often the second time they return, they tell a story of a positive family history of family members who had not been diagnosed before, because it develops so gradually. And if it develops in adulthood very gradually, people adapt to it and not always have taken the time, the effort, the possibility to visit a neurologist for that. Or people have been seen with by a neurologist and receive different diagnoses.
Right. There are a couple other questions having to do with genetics and the testing. How do you find out how many repeats you have?
Usually it is in our diagnostic labs, it's tested, but I'm not sure how it is in the US. But we just get a number of the length of the D4C4 region, which you can translate into the number of repeats.
But it's something you can ask your doctor, because I think in the United States, repeat size will also be included in the genetic report. Yeah. But if neurologists are not too familiar with FSHD, they only read the conclusion and tell the patient you do have or do not have FSHD and might not discuss the repeat length. So best thing is to go back to the neurologist who diagnosed you or the geneticist and ask for the repeat size.
Okay.
And Joan, do you know, I think in general, this is being included in genetic reports, isn't it?
Well, it depends. It's included, but it's in a way that, especially the Southern blot test, they give you the fragment length, which is not the same as the number of repeats, and then we have a little formula that you use to figure out how many repeats it is. And it's not simple. You'd think they could just say you have 6 or 7 repeats. Okay, we have, let's see, well, maybe we should move on just out of interest of time, and then we'll come back to some of these questions.
Yeah, that's okay, great. Great. So we'll move on with the reproductive counseling options, and I would like to start by saying that these reproductive counseling options vary per country and are amongst others dependent of laws and legislation, but also of the available facilities. So not all hospitals and not all laboratories that are nearby have the expertise that is needed for FSHD diagnostics and this counseling. So I will discuss all up-to-date possibilities from a Dutch perspective, but there might not be, all these possibilities might not be available for the participants today. So maybe your own clinical geneticist can help you put these in the US perspective, or June. So before future parents can be counseled on reproductive options of FSHD, they need to be adequately counseled on a few things, and they need to start with Fshd genetics and inheritance, and with the high variability, clinical variability, and the incomplete penetrance of FSHD, like we just did. Then with discussing all available options regarding family planning, and region-specific options in both prenatal diagnosis and pre-implantation genetic testing, but also region-specific legislation, because it can vary between states, between countries. And also, of course, the risk of prenatal diagnosis and pre-implantation genetic testing. So the general options that are available for all familiar diseases are to accept the risk from passing on, of the risk of passing on the genetic variant, to refrain from having biological children, to have adoptive or foster children, or to use egg or sperm donation. But recently, 2 options were added to this list for FSHD type 1 patients. So these are the pre-implantation genetic tests or diagnosis, which is called PGT in short, and prenatal diagnostic trajectory, which is PND. And I will discuss both in more detail hereafter. So through pre-implantation genetic testing, the birth of a child with a specific severe genetical disease can be prevented. So it's a test used to identify a specific genetic problem in embryos, which are created through in vitro fertilization. So an IVF procedure is necessary for the pre-implantation genetic testing process. PGT is also sometimes called embryo selection, but the requirement for PGT in the Netherlands is that it concerns a severe genetic disease that cannot be treated adequately. After an IVF procedure, the obtained embryos are biopsied. So it's usually a 3 or 5 day stage embryo, in which a few cells are taken off, and they are genetically analyzed to see which embryo, so there are usually multiple embryos, so which embryo has the genetic problem and which embryo does not have the genetic problem. The embryos that do not have the genetic problem are transferred back into the uterus, and pregnancy chances are about the same as for a usual IVF cycle, so 25 to 30% per transfer. There are a few difficulties when it comes to PGT in FSHD, and PGT is only available for monogenetic disorders, so it's only available for FSHD type 1 and not for FSHD type 2. It's only available in familial cases, and that I mean that de novo mutations, so people that have a new mutation and their parents do not have the mutation, it's not available because you need to give the DNA of both parents and an affected family member to the lab that's going to do the PGT. There is a risk of misdiagnosis in PGT used in FSHD because of the specific genetic problem in FSHD. This risk is below 5%, but it's still there. And because of this risk, prenatal diagnosis during pregnancy is still advised. So if a pregnancy occurs, you still need to test, or it's advised to test the fetus if it has FSHD or not, because of this small risk. I will explain a bit more about prenatal diagnosis here. Prenatal diagnosis means diagnosis before birth. So after a woman gets pregnant, it can be used to screen fetuses for instance, chromosomal defects such as Down syndrome. However, it can also be used to test a fetus for a specific genetic problem, such as FSHD. There are multiple ways to use prenatal diagnosis, the first I want to discuss is non-invasive prenatal testing, which is done through the blood of the mother, but that's not available for FSHD, so I will not be talking about that from now on. The 2 tests that are available are amniocentesis, which means that a bit of amniotic fluid is taken through the abdominal wall. But the fetus can also be tested through a chorionic Phyllis biopsy, which means that the bit of chorionic villi is taken vaginally and then tested. So these are the 2 options available for FSHD. So a chorionic Phyllis biopsy can be performed from the 11th week of pregnancy, and amniocentesis from the 16th week of pregnancy. Both have a risk of miscarriage of a half %. After these biopsies, a southern blot analysis is performed, which takes about 4 weeks to get results back. So it takes 4 weeks till you know if the fetus has genetic predisposition for FSHD or does not. Because of the difficulty of this test, sometimes repeated testing is necessary because an insufficient amount of DNA has been produced during the biopsy. So because of the timeline, because the chorionic Phyllis biopsy can be done earlier than the amniocentesis, most diagnostic labs prefer chorionic Phyllis biopsy. Because the first results will just be in at 15 weeks. And if you do an amniocentesis around 20 weeks, so that's quite late in pregnancy. And if the prenatal test detects the genetic predisposition for FSHD, pregnancy termination can be considered. However, as I explained before, this is amongst others dependent of legislation, the wish of parents, and the duration of the pregnancy. So it's not always an option. Unfortunately, both prenatal diagnosis and pre-implantation diagnostic tests are not available yet for Fshd type 2 because of the diagenic origin of the disease. I'd be happy to take questions about these options now. There's just a small, or I can just proceed with the pregnancy and delivery part and we'll do the questions afterwards.
Why don't we do that?
Okay.
Continue for now.
Okay, this is just a couple more slides. So there is not much literature available on the pregnancy outcome in FSHD, but a few articles that are available describe that pregnancy outcome in FSHD is usually favorable. FSHD has most likely no effect on fertility and does not increase the risk of miscarriage, preterm birth, or birth defects, and it also does not increase the risk of pregnancy complications such as gestational diabetes. Some FSHD patients do report an increasing severity of symptoms during their pregnancy, which might be irreversible, and this has about 12 to 24% of FSHD women that got that were described in these papers. The symptoms that they described are a general decrease in strength, an increase in frequency of falling, an increase in existing or newly onset pain. And furthermore, severely affected patients with scoliosis or hyperlordosis are at risk for pulmonary problems during pregnancy because of the temporary reduction in pulmonary function that they get. Therefore, we recommend regular control visits to the outpatient clinic with expertise in neuromuscular disorders before and during pregnancy in FSHD patients. The same articles that described pregnancy in FSHD also described a bit about delivery in FSHD, and they found that there seemed to be an increased risk of instrumental delivery and cesarean section delivery, mainly in severely affected women. And presumably this difference is due to the abdominal and pelvic muscle weakness, making it difficult to push during the last phase of childbirth. Therefore, our advice is for FSHD patients to give birth in a hospital. Also, general anesthesia is associated with risk in all muscular dystrophy, so local anesthesia is preferred in FSHD patients when possible and when necessary, of course. So, to summarize, FSHD type 1 is an autosomal dominant repeat disease caused by a repeat contraction of the D4-C4 region on chromosome 4 with an inheritance risk of 50%. And for FSHD type 2, both prenatal diagnosis and pre-implantation genetic testing are available. And FSHD type 2 is a diagenic inheritance of a diagenic disease combining both a relative repeat contraction of the D4-C4 region and an SMCHD1 gene mutation mainly, with a variable inheritance risk, and both prenatal diagnosis and pre-implantation genetic testing are not yet available. We wanted to show you the American Academy of Neurology guideline from 2015, in which recommendations are, amongst others, about FSHD diagnosis. However, information on genetic counseling is not yet included in this guideline. And June has recently initiated rewriting this guideline, so this revision will follow soon. And I also want to show you the review we wrote on the subjects we discussed today. And if anyone's interested in reading this review, please contact me and I will send you the PDF version. I want to thank you for your attention, and I want to thank the FSHD Society for the invitation to speak today. And this is my email address if you want to contact me or to receive the PDF of the article. And let's talk about the remaining questions here.
Okay, thank you so much. Yes, there's so many questions, so I will try to get through as many as we can. Yeah. I think now a number of people had questions about the availability of pre-implantation genetic testing for de novo cases. Can you explain a little more why? I think people are imagining you just grab a thread of DNA and go like, count the D4Z4 repeats and you have your diagnosis. Why can't that be done? And why do you need to have DNA from relatives in order to do the pre-implantation genetic
The problem with PGT in FSHD, and that's also why it had not been done in Holland before this year, actually, was that you cannot, the normal FSHD diagnosis is done during southern blot analysis, which requires a lot of DNA, so like a chunk of a tissue, and it takes a couple of weeks. And you can imagine in PGT, you only have a couple of days because you need to re-implant the embryos, and you do not have a chunk of DNA, you only have a few cells. So you have too little DNA for a southern blot analysis, and you do not have the time for a southern blot analysis. So what they need to do was to create a different sort of method to diagnose FSHD for these embryos. So you cannot use the normal diagnostic process for FSHD. Well, the problem of the genetic testing using a different method is that the D4Z4 region in which the FSHD problem lies is very, as we call, distal on the chromosome. So it almost falls off the chromosome. It's the most end part of the chromosome. And usually when PGT analysis is performed, they take a few references in the DNA before and after the genetic problem. And we cannot take these references after, because the gene is already falling off the chromosome. So you can only take these references in front of the D4Z4 region. And to do that correctly, you need to have more reference DNA. So this is a bit technical, but to make sure you do not get any errors in that analysis, you need to compare this DNA from the embryo to the parent. The parent that is affected, the parent that is not affected, but usually the parent that is affected, and more family members, to make sure you do not make any mistakes in that. So it's still a new method. It might change in the future, but for now it's not, because of this error of this risk of errors, it's not possible. Or it is possible, but there's a high risk of errors, and that's the problem. That's why they won't do it.
Mm-hmm. Understood. Here's an interesting possible workaround someone is asking about. So an individual with FSHD has a child who is also has FSHD. Now, if they're considering having a second child, can the first child provide the DNA to establish markers to do pre-implantation testing on the second child?
Yeah, definitely. Okay. Yeah.
And even if the first pregnancy is terminated after prenatal testing, which is done in the conventional mode, you have a member, although it never lived, but it's still a family member affected, and that is already sufficient.
Okay, very interesting. So there's a question, which I think you answered, about whether you can find the number of repeats through pre-implantation genetic testing or prenatal diagnosis. So for PGT, you're not measuring the repeat size, you're looking at adjacent markers, so you can't, correct? But with prenatal diagnosis, you have a larger number of cells and you do southern blot, so you could establish the number of repeats for that, correct? Yeah. Okay.
But it will be the same as in the affected parent.
Yeah.
The repeat number does not increase or decrease in subsequent generations.
Okay, thank you. Let's see. Sorry, I'm going through and So many questions.
I see them popping up.
Here's
here.
another question. If you have you're trying to have prenatal genetic testing and your parent, maybe you may or may not have had FSHD, they were never tested. Is it possible to retrieve that parent's DNA to establish a second case, like from hair or some other,
You mean if they aren't alive anymore?
if they're not alive anymore, is there a way to still, it probably depends on the quality of the DNA that you could.
I guess it can be done. I'm not sure what Nicole wanted to say.
Well, for most genetic disorders for which simply sequencing is performed, it can be done.
Yeah.
Not on hair in a diagnostic setting. That's more the things we see on TV in movies, I think. But often for many family members who have deceased, there is a biopsy taken in a diagnostic procedure for something else. So for many people, there is some material in some hospital somewhere, and that is then sufficient. But with FSHD, you need more DNA overall. So then I think it will be more difficult. I never came across that question, but I think overall, if we want to do diagnostic testing and ask the lab, can you do it on the DNA which is available in your diagnostic lab? They say, no, we want fresh blood and we want sufficient DNA to start testing for the southern blot.
I know in other diseases than FSHD, it is possible to do it with less family members, but that should be discussed with the person who does the PGT. So I guess they should just ask their clinical geneticist to discuss it with the person who does the PGT in their region, if it's possible or not. I don't think there is one answer to this question.
Okay. Oh, there's a question again about PGT that it's a family where there are twins who have de novo mutation. Can so that can that twin serve also as the second source of DNA for PGT testing?
I don't know.
It's a monozygotic twin, so identical
Yep.
twins, so they have identical DNA, and I think that is nothing else than the DNA, the patient itself. So
yeah,
I think it's a very nice question illustrating that it's nice to have a clinical geneticist to ask this question. My first impression would be no, because of the identical nature of the DNA, but I think it's good to ask the geneticist.
Yeah.
So let's see. Here's a question. If you're a couple, you're not planning to have a baby right away, but to plan for the possibility to be able to do pre-implantation genetic testing, would it be a good idea to store and save the DNA from say an older affected parent, so that it's available for the time when you need it?
I guess you can also already take this question to the clinical geneticist and ask it to the person who does the PGT in the US to discuss it and to discuss the possibilities and to see if they already need the blood. So if they already have it there, they can already start the procedure. And of course, you do not have to do the IVF cycle already, but you can do the test that is needed before. I guess I would just start by going to the clinical geneticist and to start the process. And then you can do the test, and you at the time you are ready to start a family, then you can do the IVF cycle and make sure the test is done. But then it's already the I'm not sure, voorwerk.
Prepared, yes,
Yeah.
because it's important to realize, at least in the Netherlands, that these preparations take time.
Yeah.
And the chances of having a pregnancy after IVF is not 100%, of course. That's what Sanne pointed out. So sometimes there are more cycles necessary. And therefore, with the preparation time, if you have FSHD and you want to have, if you would like to have a child with this technique, it's important to go and visit a clinical geneticist early.
Yeah.
Sanne, you just attended a clinic of the geneticist in the Netherlands who's doing these clinics. Can you tell a little bit about the waiting time or the procedure time between the first visit and the start of the procedure?
Well, it depends per disease they talked about, but it is definitely at least 6 months. So there also was a couple, this Monday it was actually, there was a couple that did not plan to have children yet, but they wanted children in the future. So they already started the procedure, so they could get blood from the family to proceed with the test, and they just wanted to wait after the test to see when they were ready and initiate the pregnancy or the IVF cycle. So there are a couple of months, definitely 6 months this test takes. So I guess you can never start too early.
And then you are referred to the gynecologist and you have to start taking, well, blood tests need to be done. There's a waiting list for starting with IVF, etc., etc. So it is all more complicated and takes longer. So
yeah. So the test is a couple of months, but also a waiting list for the biopsy, for the embryonic biopsy, for the IVF cycle. So there were couples that were told that the entire process would take 2 years before they could start. So I guess, yeah.
So this information is so important because there's so much planning involved.
Yeah, exactly.
Yes, and also, June, in the Netherlands, the age at which women have their first baby is, I think, 29.5 or something, which is one of the latest countries worldwide. But overall, the fertility decreases after the age of 30. So the chances of becoming pregnant with IVF also reduces with aging, and then 30, 31 is still very good. But if you are 36, 37, it's not only the whole procedure, but also the normal aging, which reduces fertility both in natural cycles as in IVF.
Right. There's a note in the Q&A from someone who's mentioning a lab in Spain that was able to do this is prenatal diagnosis, not pre-implantation, but that it was able to do it in 3.5 weeks, which is about half the time it takes in the US, which usually is about 6 to 8 weeks. So they're called Biodonostia Health Research Institute. So if they can do it that fast, that's certainly valuable. But if I recall, though, sending material internationally can be a logistical challenge also. So that's something
to take more time.
Question: can you do pre-implantation genetic testing with a frozen egg and sperm using, I guess, I mean, that would be by definition in vitro? And
I guess I'm not sure, actually. I guess it can be done, but
well, as far as I understood so far is that there are embryos which are being tested, and the non-affected embryos will be replaced or stored, frozen. So there will be a selection before storage. So if you have a good stimulation of egg cells, and there are plenty of egg cells, and you have a good number of embryos, they grow all embryos and then select and replace one, in elderly women sometimes 2, and then the other embryos which are not affected will be frozen and can be used in a new cycle if necessary.
Okay. Yeah. And there was a question relating to, because let's pivot to risks to the mother who has FSHD of childbirth. This is related to that because they're wondering if it's possible to do the PGT and then have a surrogate pregnancy to reduce the chance of any risks to the mother who has FSHD.
Yeah, definitely. It can also be done. Yeah. It also has a lot of regulations, so I would start even earlier if you want to do that, but yeah.
So, and then scrolling all the way back up, there's someone wondering if women with FSHD are at greater risk of experiencing back labor during delivery.
I'm not sure what this, do you know what that means, Nicole? Yeah.
Do you mean a delay in delivery, a delayed labor, prolonged labor, back labor?
Back labor, I think it's maybe only used in America, and I'm not even technically sure what the term is, but I think it's a difficult labor where it's just very hard for the mother to for the labor to advance, and maybe it feels like the baby is like pushing into the back rather than downward.
Yeah. Yeah, well, especially in severely affected FSHD patients, labor can be difficult because of the weakness of abdominal muscles and truncal muscles, and also pelvic girdle muscles. So the ability to push might be less good, and therefore the delivery may not proceed as fast as you want to. So that's why there is a higher risk for C-section and instrumental delivery, but it's mainly in severely affected women, but there is an increased risk, yeah.
Okay.
But it depends on how affected the mother is. So if the mother only has some facial weakness and some shoulder girdle weakness, it should not really be a problem.
Okay. A question from someone saying, talking about the impact and risk for women with FSHD and symptoms. I was told by my physiatrist that there's a 1/4 chance that my condition would get much worse. Is that true?
Yeah, it depends on which article you use, but the first article we used said it was a 12% chance, and the other said 24. So if you use the second article, it's a 1/4. Yeah. Okay. I'm not. The article states that it's usually irreversible, but not in all patients. So yeah, it remains a bit vague. You're not sure.
Okay. Back to the PGT question. Is there a risk of introducing any additional or new genetic abnormalities in the process of doing the PGT?
No, definitely not. They only test the few cells that they have biopsied, and the rest of the embryo stays intact.
Okay. This is a follow-up question to the risk to women for having more severe symptoms. Were the women that experienced a progression, were they more severely affected to start with, or were they, were there any other risk factors that predisposed them to?
It's not stated in the article, so I don't know.
It's not hard, yeah. You don't know if it's age or it could be any.
I guess we need more literature on this subject, definitely.
Okay. And there was someone picked up on your comment about general anesthesia and the risk for that if in muscular dystrophy. They want to know why it's riskier and whether certain types of, she refers to twilight short-term anesthesia. Is that true even for that type of anesthesia?
Well, maybe I can answer that question, Sanne.
Yeah.
A general anesthesia in neuromuscular disorders overall might be problematic if the anesthesiologist is not prepared for it. But what needs to be done is that certain anesthesia medication should be kept. I'm sorry? Avoided, right? Thank you. And during general anesthesia, the degree of muscle relaxation should be measured. So the dose of muscle relaxants are exactly enough, but not more than that, for the level of relaxation needed during the general anesthesia. But if the general anesthesiologist has time to prepare for it and it's not an emergency operation, it can definitely be done in patients who are not severely affected in respiratory function.
Thank you.
And therefore, if someone is going to deliver with FSHD and trying to start with the vaginal delivery, it's still important to have a meeting or an appointment with the anesthesiologist before, so he or she knows that this patient has FSHD and takes notes what makes a plan of which medication is going to be used.
Okay. Sorry, we're running a little over time, so thank you. I hope that's okay. You probably have to rush off somewhere. So let's maybe one last question here. In your writing your paper, did you come across data on the success rate of PGT cases versus many adverse outcomes?
They haven't really done it much in Holland yet because they started this year. But the risk of misdiagnosis is below 5%, so it's quite low right now, and the chance of getting pregnant from the PGT is the same as in the IVF, so yeah, 25 to 30%. So I guess, Nicol, we do know a few FSHD patients already that have done PGT successfully in Holland and without any complications.
Yes, and previously patients who were referred to Belgium, but it was already allowed earlier.
Yeah.
And we are all very near to each other. We're all very small countries, so that's only 2 hours drive, another country.
Oh, there's one more question that occurred to me relating back to the anesthesia. Would an epidural be okay or better,
Yes.
safer? Yes.
Yeah,
Great.
definitely.
Okay.
And once more, general anesthesia can be safe as long as the right medication is being used. It just ask for preparation.
Yeah.
Okay.
Okay, thank you so much.
Thank you, everybody.
Bye.
Bye.